Welcome to this video. In this video I want to talk about the topic of atrial fibrillation, which is a really important thing in general medicine, and for short atrial fibrillation is often abbreviated down to AF. So let me just outline the purpose of this video. So firstly we'll talk a little bit about what atrial fibrillation actually is, but we won't dwell too much on that. I'm assuming most of the people watching this are medical and already have a bit of an idea about what atrial fibrillation is. The main thing that I want to discuss in this video is about how atrial fibrillation is a spectrum, and on one end of the spectrum you have paroxysmal atrial fibrillation, and on the other end of the spectrum you have persistent atrial fibrillation. But those are the two extremes of a whole spectrum, and there's a huge bit in between that wouldn't fit into either of those two labels, and which we just call atrial fibrillation. And this is something that really confused me when I first started out in medicine. I used to think there were two conditions: paroxysmal atrial fibrillation and persistent atrial fibrillation. Paroxysmal was episodic atrial fibrillation, and persistent was you were always in atrial fibrillation. But that's not how it is. Those are the two absolute extremes, and there is a huge bit in the middle of this great big spectrum. And something that used to really annoy me is when people in patients' past medical histories would just write AF, and then they wouldn't clarify whether it was paroxysmal or persistent. And in my head it was really bad that they weren't clarifying which one it was, because I wanted to know, was this something that the patient was always in, or was it something that they just went into episodes of? But actually now I understand why you don't need to put that clarifier, because most people don't have one of those two extremes. They're somewhere in between, they're in the middle, and that's why it's okay actually just to write atrial fibrillation or even just AF in a person's past medical history, why it's not actually really that important to clarify which of the two it is, and indeed why it's not actually often possible to categorize it as either paroxysmal or persistent. Those are the absolute two extremes. So let's go over firstly then what atrial fibrillation actually is. A little brief discussion of what atrial fibrillation actually is. So for this we're going to need a picture of the heart, a very basic picture of the heart. So this is more a physiological picture of the heart. However, if you are very skilled at echocardiograms, you can actually get the probe into a right position to take a slice of the heart at a very sort of slanted angle so that it actually does look like this. If you know what you're doing, you can actually get the axial view that does look like this. And I'm just trying to figure out how this program has worked. They've updated this program and now I'm not sure. Here we go, here's the probe again. So obviously this is left atrium, right ventricle, left ventricle. Now, atrial fibrillation is a condition of the atria. It's not a condition of the ventricles are fine, it's a condition of the atria, and it's a condition that means that the usual conduction properties of the atria is broken in some way, and the pathology of it isn't, I don't believe, completely understood. It's certainly not something that I have a great deal of understanding of. However, the basic understanding that I do have is that if someone has atrial fibrillation, whatever part of the spectrum that we're going to discuss later they are on, it means that there is an issue with the conduction system of the atria. And this abnormality of the conduction system leads to a breakdown of the ordered electrical activity that usually occurs in the atria, and instead the electrical activity goes completely haywire and the atria no longer contract properly. Instead they just shudder, and that's what fibrillation actually means. It just means shuddering. So in atrial fibrillation, the atria do not contract, of course, what they're supposed to do. In a beautiful, young, healthy heart, the atria both contract down, push blood into their respective ventricles, and then the ventricles contract ventricular systole and push the blood into the great arteries. In atrial fibrillation, the atria no longer contract, instead they just shudder all the time, and that's what this means. And the reason that they're shuddering is because the electrical activity is no longer ordered, it's no longer able to actually create synchronized contraction of all the cardiomyocytes in the atria, and instead there's just chaos, absolute chaos. the cardiomyocytes are all contracting at different times, and therefore you just end up with the two atria shuddering. That's what atrial fibrillation is, and this has a pattern on the ECG, and it's seen in all 12 leads of the 12-lead ECG. I'm just going to draw the rhythm strip because I'm not about to draw out the entire 12-lead ECG, so I'll just draw out one lead of the ECG, which is the rhythm strip, which is lead 2. So you no longer see the P waves because the P waves are, they represent the ordered electrical activity of the atria. So you just sort of see a shuddering line, which is atrial electrical activity, and then once in a while, the AV node, which is here, will let through a electrical impulse, and then that will travel down the bundle of the His. Remember, the ventricles are fine in atrial fibrillation. The ventricular conduction system is still working, and the AV node is still working. So every once in a while, the AV node will let through a impulse of electrical activity coming from the chaos that's occurring in the atria, and then you'll get a QRS complex, and then you'll get the T wave afterwards, and then it will go on like this, and then you'll get another one conducted. So you'll see something like this, and the AV node will let through, hopefully, the correct number of electrical impulses. So even though there's chaos occurring up here and the AV node could potentially be letting through hundreds of impulses, it usually doesn't. It usually is working and it controls the number going through, and therefore usually when people are in atrial fibrillation, their heart rate isn't out of control unless there's a reason for it to be out of control. So if the person is septic or if they become dehydrated, of course, these things would, in a healthy heart, lead to you developing a sinus tachycardia, i.e. the AV node gets reprogrammed in those pathological situations to allow through loads of electrical impulses to create a tachycardia. And in those situations equally, if you've got atrial fibrillation, the AV node will reprogram and let through more electrical impulses, and therefore you will develop a tachycardia in those instances. But that is the AV node doing what it's supposed to do. It would do the same thing even if you were in sinus rhythm. So the big difference is that things are no longer regular, so the QRS complexes coming through in someone with atrial fibrillation will be classically irregularly irregular. Okay, so there's the basic discussion of what atrial fibrillation is. Now on to the main topic of the video, the fact that this condition is a spectrum. So I'm just going to draw a line, as we do for spectrums. And on one end of the spectrum, you have this condition called paroxysmal atrial fibrillation, and on the other end of the spectrum, you have persistent atrial fibrillation. So this end can be persistent. I always get confused as to whether persistent is spelt with an A or an E. I apologise if I've got it wrong. I've gone for an A. So persistent on that end. I'm now doubting myself. I think it might be an E, but never mind. The spelling isn't the main issue here. So, and on the other end you have paroxysmal. And then you have this massive stretch in between. So this is supposed to represent paroxysmal over here. This is supposed to represent persistent. And then there's this huge patch in between. And this patch you would call neither paroxysmal nor persistent. You would just call it atrial fibrillation. And all of this entire spectrum you could just call atrial fibrillation. However, if someone is right over in this part, it's nicer to call it paroxysmal atrial fibrillation, or PAF, and if someone's right over here, it's nicer to call it persistent atrial fibrillation. And by the way, when people say PAF, it usually means paroxysmal atrial fibrillation, not persistent atrial fibrillation. Just a heads up on that one. So let me explain what I mean by this spectrum. So, we'll start off by talking about what paroxysmal atrial fibrillation is. So, in individuals with paroxysmal atrial fibrillation, they are not always in this rhythm. Their atria are not always fibrillating. Most of the time, in fact, their atria are in sinus rhythm. Their atria are functioning perfectly, their heart is in sinus rhythm, they will have P waves on the ECG, the line will be nice and flat with P waves in front of every QRS complex, and the QRS complexes will be regular and everything's beautiful. So most of the time they are in normal sinus rhythm. And then for very short periods, less than 24 hours, they will occasionally go into atrial fibrillation. They will have short episodes of atrial fibrillation once in a while, and then they will come out of it and go back into sinus rhythm. in people like that, where they have very short, very exaggerated episodes of atrial fibrillation, and usually these episodes will be extremely symptomatic for them. They'll go into an episode of atrial fibrillation and they will feel it. Their AV node will not be used to it. I talked actually about how the AV node usually is very good at making sure the number of QRS complexes that, the number of electrical impulses that are actually conducted to the ventricles is controlled. However, in people, that's only once the AV node has got used to the atrial fibrillation. So when someone initially goes into atrial fibrillation, the AV node doesn't know what's happening and it can't cope with it. And initially it will let through far too many electrical impulses and you will get a tachycardia, a tachyarrhythmia. In people where the atrial fibrillation goes on and on and on, the AV node then gets used to it and controls the number of electrical impulses going through. And what I said earlier is absolutely correct, that usually they're in a normal heart rate. However, in people who get these paroxysmal episodes, they might only get one every 5 years maybe. So when they get one of these episodes, the AV node doesn't know what's hit it, and it lets through far too many electrical impulses, so they go really, really fast, and they feel palpitations, they might get chest pain, they'll feel short of breath, tight-chested, they will feel maybe even lightheaded, they might even faint, cardiogenic syncope. So they have these short episodes of atrial fibrillation that are usually heavily symptomatic, that usually often bring them into hospital, and then they come out of it, go back into sinus rhythm and carry on with their life for a couple of years, and then they have another episode. That is paroxysmal atrial fibrillation. If you have short, heavily symptomatic episodes in between huge long periods of sinus rhythm, that is what we call paroxysmal. Then on the other end of the spectrum, there is persistent atrial fibrillation, where the person is in atrial fibrillation continuously. They are never ever in sinus rhythm. They are in atrial fibrillation and they will continue to be in atrial fibrillation for the rest of their life. So their atria are never going to beat properly ever again. They're just going to shudder on and on and on, fibrillate forevermore. So that's the other end of the spectrum, persistent atrial fibrillation. And then there is this huge bit in between, which is the person may be in atrial fibrillation for many, many weeks maybe, but then they might come out of it for a few weeks and then they might go into it. So they aren't either paroxysmal atrial fibrillation or persistent atrial fibrillation. They have episodes of atrial fibrillation and episodes of sinus rhythm, and they go in and out of it. And obviously the more they head over to this side of the spectrum, the more time they spend in atrial fibrillation and the less time they spend in sinus rhythm. And the more they are to this end of the spectrum, the more time they're in sinus rhythm and the less time they're in atrial fibrillation. And in these people, you would not classify their atrial fibrillation as either paroxysmal or persistent. You would just call it atrial fibrillation. And this is really important to understand, because you will see people who have been diagnosed with atrial fibrillation in 2010 maybe, and then you might see in their record on the computer systems an ECG from 2014 where they're in sinus rhythm, and you'll think, but they were diagnosed with this atrial fibrillation that they were discharged with, i.e. we thought it was going to go on forevermore, but it evidently wasn't persistent atrial fibrillation, because when we saw them again in 2014, here's a beautiful ECG where they're back in sinus rhythm. So it's very important to understand that there is this huge bit in the middle here. Atrial fibrillation is not just two conditions, persistent and paroxysmal. No, there is this huge bit in between where people are going in and out of atrial fibrillation. Now, a little bit about pathology here. Now, so, atrial, and I'm not going to go into detail of this because I'm not a cardiologist and I won't pretend to understand this properly, but if you have atrial fibrillation, it does mean that there is something wrong with your atria. Something has damaged the conduction system in your atria, or something has damaged part of the myocardium. And it is usually actually the part of the myocardium closest to the pulmonary veins. So remember, let's just add on to our diagram. The left ventricle is filled up by the 4 pulmonary veins. So here they are, 2 from each lung. So left on this side, right on this side. So these are representing the pulmonary veins, and around each pulmonary vein, there is some myocardium, some atrial myocardium, and usually it is these parts of the myocardium that break in people with atrial fibrillation and which lead to the abnormal generation of electrical activity that then sends everything haywire. So usually it comes from the left atrium rather than the right atrium. So in people with atrial fibrillation, there is some abnormality of the myocardium of the atrium. Now, you might not actually be able to see this. Certainly with echocardiogram, you might not actually be able to see the damaged myocardium of the atria from where the atrial fibrillation is coming from. In some people with atrial fibrillation, it's really, really obvious that there is an abnormality of the left atrium because their left atrium is enormous. So many people with atrial fibrillation, you see a hugely dilated left atrium, which evidently shows you they've got structural abnormality of the left atrium, so something's evidently gone wrong there. However, other people with atrial fibrillation, you can echocardiogram them and you won't find anything wrong with their left atrium. Their left atrium looks perfectly normal on an echocardiogram. In principle, you could go one step up. You could go and give them a cardiac MRI, which is the best imaging modality that exists at present for the heart. So you could cardiac MRI them, get beautiful pictures of their heart, and you might even still then not be able to actually find anything wrong with their atrium. However, it is generally believed that there is a problem with either their left atrium or their right atrium, usually their left atrium, usually the parts of the left atrium around the pulmonary veins, that is causing this arrhythmia. So there is something wrong with their heart. Now, what this abnormality means is that they have a tendency to go into this chaotic rhythm of atrial fibrillation. It doesn't mean that they're always going to be in it. And here's the thing that I really want to communicate to you. You might say, and this is another thing that really confused me when I started in medicine. One of the commonest things you see in hospital is people going into atrial fibrillation. They were in sinus rhythm, they go into atrial fibrillation, and usually the reason is some physiological disturbance. So they might have had some disturbance in their potassium. So I'm just going to take the two most common examples. So potassium is one of the reasons. We really worry about the electrolyte potassium and the levels of it in people's blood because if it goes either too high or too low, it precipitates cardiac arrhythmias. The other thing is dehydration. So when the fluid level in your body goes too low, that is what is known as dehydration, and it leads to the volume of blood in the vessels going down as well, and that, for reasons that I won't pretend to understand, leads to cardiac arrhythmias. And in fact, I would say dehydration is even more common than potassium. So a really common story is someone at home, maybe they live alone, they're elderly, they get gastroenteritis, viral gastroenteritis, a very common tummy bug. They feel really, really unwell. They stay in bed all day. They don't even have the strength to go and get themselves a drink. They become more and more dehydrated. More and more fluid leaches into the gut, which is what happens in gastroenteritis. So they lose fluid from their intravascular space and from their tissue space, and their intravascular volume becomes deplete, and then they go into atrial fibrillation, develop chest pain, develop shortness of breath, chest tightness, and then they end up coming into hospital. And you give them huge amounts of fluid and they come out of atrial fibrillation. And to me, that meant that surely they don't have an abnormality of their heart because their atrial fibrillation was precipitated by this physiological derangement. It was precipitated by the dehydration. However, that is not right. They do have an abnormality of their heart. They are on this spectrum here. Maybe they're over here on the spectrum, so I might just mark them out. They might be here. So most of the time, they are in sinus rhythm, but they can go into episodes of atrial fibrillation. And these episodes of atrial fibrillation might be triggered off by something and will be triggered off by physiological derangements such as dehydration and potassium. To drill what I mean here in more, if I took someone young, let's say I took a 20-year-old with a perfectly healthy heart, no heart disease whatsoever, and I made them dehydrated, and I dehydrated them and dehydrated them and dehydrated them. Let's say I took them to the desert and gave them no water, dehydrated them more and more and more. Would they go into atrial fibrillation is the question. Well, eventually they would, but they would go into atrial fibrillation at probably roughly the same time as they would go into ventricular fibrillation, and then they would die. So remember, ventricular fibrillation exists as well. It's not as common because people die of ventricular fibrillation very quickly. So the ventricles can fibrillate just as the atria can fibrillate. So when electrical activity goes haywire in the ventricles, loses all order, the ventricles will fibrillate, they'll shudder, and this obviously leads to lack of a pulse, and therefore no blood goes around the body, no blood goes to the brain, and it leads to death within a few minutes. And if you have big enough derangements in physiology, you will go into VF. So if you become dehydrated enough, or if you derange your potassium enough, and there are other deviations as well, if you get a really bad infection, so if you develop septicemia, sepsis, this will trigger you eventually, if it gets bad enough, to go into VF, and that's a common way that people in fact die. So all of these things, they will precipitate cardiac arrhythmias. Now, in someone who is not known to have atrial fibrillation, i.e. they're not on this spectrum, their atria are perfectly fine, then their atria will go into an arrhythmia, will go into fibrillation at the same time as their ventricles. So you will have to deviate physiology so much that it will trigger both of them at the same time, and therefore it will trigger death. In people who have this condition, atrial fibrillation, there is something wrong with their atria that means that their atria are far more likely to go into this than they should be, and it will take a much smaller deviation in the physiology to trigger them to go into an episode of atrial fibrillation. So going back to our elderly person who became dehydrated because of gastroenteritis, this person has atrial fibrillation. They might be over here on the spectrum, so most of the time they spend in sinus rhythm, but they've been known to go into episodes of atrial fibrillation. This means there is some sort of abnormality of their atria. Their atria is not perfect, it's not that of a young person. So if you deviate physiology a small amount, well, not a small amount, but if you deviate physiology somewhat, if you dehydrate them, it will trigger atrial fibrillation far more easily than it would do in a 20-year-old, and therefore they will go into atrial fibrillation far before they would go into ventricular fibrillation. So you'd have to dehydrate them a lot more to actually trigger off the terrifying arrhythmia of ventricular fibrillation. But because they've got this conductive abnormality in their atria go into this arrhythmia long before it would in someone with a perfectly healthy heart, is what I'm trying to say. So having this condition, what it means is that you've got an abnormality of the conduction system in your atria that means that it will take much less of a deviation in physiology to actually trigger off fibrillation in the atria than it should do. And the more you are to this side, the lower the abnormality and the lower the tendency for you to actually go into atrial fibrillation. So if you're right over here, you only go into atrial fibrillation very, very occasionally, and for very short periods of time, whereas if you're right over here, your tendency is so high that you're actually just in it all the time, and it doesn't even take a deviation in your physiology to actually cause you to go into it. So that is why it does not actually hugely matter about clarifying whether it's paroxysmal or persistent. If you write atrial fibrillation in someone's past medical history, what that is effectively saying is it means there's some sort of abnormality of the conduction system of their atria that means that they are likely, or more likely than a healthy 20-year-old, to go into this arrhythmia, and that they will go into this arrhythmia long before they would go into the far more dangerous arrhythmia of ventricular fibrillation. Whereas in a perfectly normal atria, atrial fibrillation and ventricular fibrillation would happen at the same time. It would take the same level of derangement of physiology to actually trigger that. Okay, so that was the main lesson then of this video, that this is a spectrum, that it is okay just to write AF in someone's past medical history. Now, just a final point then, and that is to discuss the two drugs, bisoprolol and sotalol, and the difference between them. And then also I'll just say a little bit about anticoagulation. In fact, I'm just going to say a bit about anticoagulation first. So, anticoagulation, this is a massive issue. So, atrial fibrillation, why is it dangerous? It is dangerous because when the atria fibrillate, don't contract properly, you can get blood not moving properly. So, if there's... Think about obviously this diagram isn't brilliant because it's not an anatomical picture, it's a physiological picture, but imagine there might be some parts of the atria, if they're just shuddering, it's not going to be moving blood through it properly. So there might be places in the atria where blood just doesn't move at all, and it just sits there and sits there and sits there. And when blood sits there and sits there and sits there, remember Virchow's triad, and in fact, can I even remember Virchow's triad? But importantly, Virchow's triad tells us when blood clots. And one of the factors that makes blood clot is stasis, when blood doesn't move. So if you've got blood just sitting somewhere, it tends to clot. And then you'll end up with clots forming inside your heart. And what if these clots actually then move off? It will go into the left ventricle. So let's say we had a clot form in the left atrium here, it will go into the left ventricle, and then where will it be thrown off up to? It will be thrown off up into the aorta, and the three main vessels coming off are the brachiocephalic trunk, the left common carotid, and the left subclavian. And what if it flies up the left common carotid and then it goes up to the brain and blocks the blood vessel, blocks, let's say, the left MCA artery? What will it cause then? It will cut off all blood to the part of the brain that the left MCA supplies, which is a huge, great chunk of the brain, and then it will trigger off a left MCA stroke. So you can get what is called a cardioembolic stroke from atrial fibrillation. This is why atrial fibrillation is dangerous. Cardioembolic stroke. And this is the reason that we anticoagulate people. We put them on drugs that thin the blood and prevent it from clotting to try and prevent cardioembolic strokes. And the main drug that we use to anticoagulate people is warfarin. However, there is the whole new generation of drugs, rivaroxaban, apixaban, dabigatran, edoxaban, the NOACs or DOACs, that are starting to come in, but warfarin is still the main one that is used. So that's a little bit about anticoagulation. Obviously, you need to putting someone on anticoagulation is a big commitment. It thins their blood, it makes them bruise easily. If they cut themselves, their blood is going to take a lot longer to clot, so they'll bleed and bleed and bleed. It isn't without risk. So you need to do a risk-benefit analysis. And obviously, if they're going into atrial fibrillation once every 10 years, i.e. they're right over here on the spectrum, then you're probably not going to anticoagulate them for that. Whereas if they're in atrial fibrillation continuously, then you're probably much more likely to anticoagulate them for that. But again, there are situations where even if they're in persistent atrial fibrillation, you wouldn't anticoagulate them. If it's a really frail elderly person who is very prone to falling over and hitting their head, then you're not going to anticoagulate that person, because if they fall over on a good dose of warfarin, then they're probably going to have an intracranial bleed. So overall, you're going to harm them rather than do them good, and the benefit versus the risk isn't worth it in that case. So anticoagulation is a complicated issue. You need to try and think, is this person going to benefit from anticoagulation, or am I going to do them more harm? And you need to think, if this was me, or if this was my mother or my grandmother, would I want them to be anticoagulated? I always try and think, if I was this patient, what would I actually want to be done? Would I take anticoagulation if I was prescribed it, if I had atrial fibrillation? And if the answer is no, then the answer is probably that the risk outweighs the benefit in that case. So that's anticoagulation. Let's now talk about bisoprolol and sotalol. So bisoprolol versus sotalol. So bisoprolol is the big drug that we prescribe to people with atrial fibrillation to try and rate control them. So this is for rate control. And sotalol is the drug that we use. And by the way, this is what we do in the UK. I don't know what's used in other countries, but this is what we use here. So I apologise if different drugs are used in different countries, as I suspect they are. But in the UK, this is the basics of the drugs that we prescribe for atrial fibrillation. Bisoprolol is what we prescribe for rate control. So I talked earlier about how the AV node should control the number of impulses that come through from the atria to the ventricles. However, it doesn't always actually work perfectly like that. Often, if you've got conduction abnormalities of the atria, then you might have some conduction abnormalities of the AV node as well, potentially, because the same sort of diseases that cause conduction abnormalities in the atria can lead to conduction abnormalities of other parts of the heart as well. Also, you have to realise that the AV node is potentially being bombarded with requests to put through hundreds of impulses per minute. And in reality, in some people, it perfectly manages to control the number that it's putting through and keeps them at a good pulse, but often it doesn't, and many people do end up going slightly too fast. If they're in atrial fibrillation a lot of the time, they end up going slightly too fast, and therefore they need to be prescribed a drug that also helps control the AV node, and this is what bisoprolol does. It's a fantastic drug for rate controlling. So you give them this drug, and this drug basically helps the AV node control the number of impulses that are being let through to cause ventricular systoles. So if someone's in towards this side of the spectrum, either in atrial fibrillation a lot of the time, and you want to try and just keep them at a decent heart rate, i.e. not going too fast, bisoprolol is the drug that you would use for rate control. Sotalol, on the other hand, is a drug that we use for rhythm control to actually try and prevent people going into atrial fibrillation. So this is a drug that you would use more for this end of the spectrum. In fact, it's really for paroxysmal atrial fibrillation. So people who are nearly always in sinus rhythm and who have episodes of atrial fibrillation that may well be triggered off by dehydration, or in fact alcohol is another one to put on here. Alcohol can trigger off episodes of atrial fibrillation. It's arrhythmogenic. So if people suddenly start consuming large amounts of alcohol and they have paroxysmal atrial fibrillation, that may well trigger them off into an episode of atrial fibrillation. So if someone has paroxysmal atrial fibrillation or is very towards this end of the spectrum, and you want to try and prevent them actually going into episodes of atrial fibrillation, then sotalol is the drug that we put them on. This is what's known as a rhythm control, to try and actually keep them in sinus rhythm, to control their rhythm rather than just controlling their rate. When they're more over this end of the spectrum, sotalol isn't going to work. It's not going to suddenly cardiovert them back into sinus rhythm. When they're in atrial fibrillation, and they're nearly always in atrial fibrillation, you can give them as much of this drug as you want. It's not going to actually bring them back into sinus rhythm. In that case, all you can hope for, the best you can hope for, is to try and rate control them, and bisoprolol is better at rate controlling people than sotalol. However, if they're very much towards this end of the spectrum, they have paroxysmal atrial fibrillation, then you can prescribe them sotalol to try and prevent them going into episodes of atrial fibrillation, and that is known as rhythm control. And both of these drugs are beta blockers. Bisoprolol and sotalol, they both block beta receptors, and that's their mechanism of action. So sotalol aims to actually cool down the parts of the atria that are broken and which are creating this arrhythmia, and prevent them from actually taking over and turning atrial electrical activity into chaos, whereas bisoprolol is acting on the AV node and telling it to calm down and control the number of rhythms or the number of electrical impulses that are going to be allowed through into the ventricles. Okay, and that's really all I wanted to actually say about atrial fibrillation. So I hope that has helped in some way. If you've got to this stage of the video, then evidently you have found it useful, otherwise you would have left long ago. So thank you for watching this video.